So I know that John said he was going to call in, and Rhonda was going to call in.
Okay.
And Jim Everly is not feeling well.
So what do you get to?
Oh, when we have a quorum, that's what I'm getting to.
Okay.
Oh my gosh. Yeah, it is really, really. Cut to the chase, Carol.
Yeah, right. TikTok.
I'm all about the storytelling. Better the story. I agree. Okay. More soothing that way. Into parable. I'll look on the way back. Thank you.
That's how history was passed down, story by story.
Seemed to work for Jesus, so.
I think that it worked with all the indigenous people, and I think that when you first started out, you know, it's like the stories of the clan going into the populace. So I like storytelling, but I also like to hear them.
Yeah, we kind of. It's on. It's the right side is the. Yeah, I'm going to pull and go anyway. Way high. Have a high chair.
Meeting you first board meeting, yeah. I was thinking so. I was like, I didn't see her left.
I'm a newbie.
I know.
Me too. Follow up.
I was there when they were signing you in.
Are you taking off in the morning, Carol?
Yeah. Yes. I remember.
It was good.
Yeah.
And it took me to get home to recognize. I was like, oh my gosh, I felt so embarrassed.
No.
What connection?
Like, you know, I
Are you on?
came to the leadership meeting. I don't know.
Mm-hmm. Yes, you did.
Yeah. I don't know where I'm going from week to week. Whatever my calendar says.
That's kind of how I feel.
Talked about this one yesterday. Really? We just mentioned yesterday. What is it?
Yeah, she was at the east side.
So the Department of Health extended my airline return to Sunday.
Are we solving problems?
Instead of when the conference ended,
I don't know if we have a
extended my flight back up to Sunday instead of.
How was that?
And it's over on the west side?
Mm-hmm.
Put our help together.
Nice.
Talk about this.
And then it's the GHW conference. And that was a good conference. It was a little bit disappointing on the suicide prevention.
Sorry.
Thank you all for. I'm good.
For lunch, this is really nice. Aspect of it. Thank you so much.
We were subwayed out.
Yeah.
Eric, oh,
So
yeah.
many subways.
About that.
No.
Right?
I think we're trying to organize something.
Plus, they
around
leave
that
us all
locally.
these myths, and we have so many myths.
Eric's a good guy. I've known him for a long time. Doesn't really pertain to our project areas, but
Something else.
it does pertain to a lot of other.
Next HCH means put the bucket out there with the rest of the.
He was in my first,
Placing.
one thing that we're supposed to ask.
Oh, both
first
here.
I was in
Some of them anyway.
Get better working, but he was a administrative specialist. We were in Las Vegas and met. He went to social media. So we kind of
He
floated
follows
away.
you, or you follow him?
I called
or you
him.
both-
When I took this job, I said, you know, I need to find housing, yeah.
Yeah.
The other is,
So, he's good. He's very, very good.
good. So
We have classrooms.
What do you mean, trauma?
So like.
Mm.
So whatever the base.
We're going to the Big Island for 4 days.
We have.
And then we make
We
stay
have
out of
our children that are in.
Wow.
Yeah. And then we're going to
A lot of trauma, a lot of times the system and all of the services. And so, we're doing the IDS right now, but they come in oil, but
Right?
as we look at expansion.
I didn't get traffic and immediately.
I agree. We have some pretty good,
See
opportunities. I know And maybe it's being underreported. Speech pathology, he's got.
Yeah, he said that.
They were south.
Okay, I was gonna say, you know, the last time you said it, you just caused all sorts of problems.
Oh, yeah, we'll make this.
It's a hard.
You know, it's funny, is we're kind of cannibalizing from our own sometimes.
You're not like, oh, let's sit next to
I
you.
also have Dr. Mudio, who's an ENT, she's actually a, and an autism. It's good to know a number.
Really?
Yeah.
And that is,
I've worked with all that.
and a lot of
And if
times,
there's any
it's not, it
opportunity,
doesn't
we might
hit
have in
the
the future.
headlines, it only hits
Really
the
connect
headlines.
with primary care and behavioral health.
When
We would all.
there's the immediate interaction
We can,
with
I'm sure we can do that.
community, so if you have a connection to somebody like the gentleman, the young guy, I think,
Because I don't want to present all
in
of
South
that.
When you're in the middle of the
You're in the
storm.
middle. I know you're in the middle of it.
We can't have that.
Differently.
No, it's not that we see it differently.
Say that
He got the report.
So that's it.
It's good to hear.
For the ones that don't fix
We,
are usually.
And then I pick you up.
please don't take that the wrong way. I mean, we're totally into it. We love it.
hard.
Yeah.
And then it's
John and
reported,
Terry,
so we
So-
don't get the statistics from it.
Why are you so mad?
It's going really well, but
The health department, I'm pretty sure,
Because
reports
you're
that
making
every day there's
decisions.
some
like a lot of hurt.
It's hard to tell what's going on.
Right.
You know,
Um,
like-
The coroner would be the one that makes the report.
Mhm.
Do you have a name?
No,
They told me
we're in that.
yeah, we're going out to see what's new for us.
We had it.
When you're talking about for beautiful, yeah.
The Oregon coast up and down, but I don't really know.
Yeah.
They track all.
75%.
I haven't yet moved into.
Use suicide.
John-
Maybe some of those
Yeah.
As a corporate arm.
Yeah.
We're gonna do
Which I think
that.
happened next week,
You didn't
or
catch
next month.
Okay, I just.
Go to Florida.
Did they just press or were they just like simulating?
Oh, maybe
So you want me to
corporate
go buy you
guys.
some tea?
Oh, okay.
It has to do with out there summer and then
If all the other stuff, we're also.
That's okay. All right. All the IT good.
Be quiet.
Oh, my God.
Oh.
I can't even imagine.
That has a
All that
has to
stuff.
do with,
We got you.
Yeah, we're all gonna move to the center.
Like the other
So we're gonna get sunny side.
Everything you put on
And
your.
we'll move the other.
You keep drawing.
So where
I agree.
I had to, yeah.
Your group,
We got the,
families.
we got, I
Oh, my
had to,
God.
so it got me, I got him.
Because
I nailed down.
Not creating a lot of social problems.
Small and,
Put them on my shoulder.
I bet they would. So I'll get some.
small and low volume.
We tried to get it.
Well, I think it's cool.
Like smiling,
Yeah.
and like, they're holding them up so they don't picture them on my head, but without
Kind
me.
of great.
That it is, move on.
Like, how do
Well,
you?
no,
Maybe I'm being very. open
You
about
are, be an accurate picture.
Primary care, mental health, medicine.
Crazy.
Yeah.
And we've linked it to the
There's a lot of.
school-based school nurses.
So I might have some of
And
those.
they channel into
Huh.
The meeting in Belfast.
that. We've got a, we'll have a
Last
nurse
time,
practitioner.
Very cool.
In
Yeah.
that role. to
Like my parents.
support the,
We're talking about
and
shit.
it's
Like
the,
talking about going back. 19th, 20th
we're
century.
piloting the model in the Sunnyvale school district through the school base.
Family trauma is totally different. Family trauma is totally
No.
different.
And it's, you know, it took a little while to get it figured out and going, and kind of bought into. We're starting
All
to
the
see the
time, and that's what you're
And I have
doing.
never,
and
You know,
the idea is
it becomes
kind of
like
work out some kinks and make it work. There's some
Oh,
value.
Oh,
they don't know what the, what the
Map
ethics is.
and how to walk, but they don't have any access.
It could be, trauma, it
It's
could
pretty,
be.
it's a pretty slick deal, and having that thing there, has been very.
yeah, right.
we've been, I remember going to all of our kids and just having the kind of the whole thing. It was wonderful,
Mhm.
but now we're connecting to our psychiatrist and actually to our young Scotland too. And we're looking to never dry off.
Yeah.
Like, I mean, it's like Seattle and Portland, and we like Seattle.
And that's brought on the right now.
I don't know. So that kind of all depends on,
Very good.
I'm trying to get it colder.
I know the schools are,
Yeah.
we have been doing, you know, the general pediatrics.
And when
Schools
he
have
did
been
that,
interested in
He qualified.
seeing if we can figure out a way to create a
I was like,
behavioral health kind of model.
Problem is
We're not all the way there. We're kind of
Phil,
have
his
this
kids
is
do like
kind
that.
of
One of
started
the
high school.
But we have it.
I think we're gonna try to.
Well, we have it
Little bit.
in our,
in May.
I mean, 4 and 5.
Attach it on that.
Hopefully,
So-
When he started.
We can add
his
it.
lawyer,
So I don't know, like,
he's gonna take on.
I
We don't
think
really want to leave it into the
Henderson's his wife, that's where y'all are.
It's,
I think what the,
don't, and
we
then
all
you'll,
are
you'll work with
so
people.
sensitive or not sensitive.
Came back.
So, yeah, the younger
I
ones.
think that because we don't have enough children.
Having somebody close on this.
Or
Well,
affected one way.
Oh, I don't doubt that. I mean,
By
then
what
the
we're
research
doing.
shows that kids even at 69 are
Well, when
susceptible
the-
to really good stuff too.
Yes, really, and that's those kind of stuff.
Absolutely.
And it translates into
Yeah, how does
physiological
it-
Very good.
increased cortisol, increased
So think about,
They like kind of pull it out, they kind of landed.
in of itself.
Something we all go through.
We
But I'm
sold our
just
house.
saying that if it's,
Right.
but if it's super
Not in a way.
sensitive, could have been like all the behavioral stuff later on, you know, you don't know. I don't
Yeah,
know.
we're,
But I guess she said the
right.
preliminary.
I think we have to verify what we can control and.
Right.
I find it,
So I think that,
well, I have a hard time getting more than, an hour and a half to spend on anything.
So anyways.
I know, people were emailing me on the way down. We got those returns. What those doing.
But it's good stuff. So these guys are,
but it was
you have to be
Yeah.
almost a full 24
and you're
hours.
in a culturally diverse room.
I know, I had a meeting on
Run us through all
Wednesday,
those
there were a
names,
lot of-
and I
all
just
that
kind of.
There were a lot of
flew out.
debates.
Was just-
Found it.
And almost
I was
178.
sorry, faces, I'm just like,
Doing
yep.
that over.
I know.
It was interesting to say the least.
We were just getting ready to, we had staff person in DC.
But Carol was
Margaret was
Uh-huh.
talking about, and ended up being.
Yeah, that was super beautiful. Weather was great.
Oh,
You wanna start?
I think Megan was trying to find out Megan to bowl. I really appreciate Dr. Howard in one location now. And hopefully once everybody gets used to it, acclimated, I've got great parking. It's just nice to know the same place that you're going.
Yeah.
Yeah.
It's more conducive
Different
to
conversation.
for it.
But I think everybody experiences different.
Right, I do think we have a couple of people on the phone, so that would probably give us the quorum if we
Okay.
wanted to start.
Well, and we can start if you wish. You're gonna have to help me walk through all this stuff.
No problem.
I'm just making it up. Me?
We'll support you all the way.
Okay. Okay, so we have some folks on the phone.
Yes.
Dan Vicini is here from OHSU.
Lori
Okay,
Brown.
thank you. Lori? Anybody else?
Tanya Chris from Yakima Nation.
Yakima Nation, I think I missed the other.
Samantha Frederick from Quality Behavioral Health.
Excellent. Okay,
And Kat
Thank you
Latay
very
from
much.
CHPW, so I'm not on the board, I'm just listening.
okay.
And
Very
Sarah
good.
Bullock
Thank you very
Dormant
much.
United.
All right,
Hey, Sarah.
Sarah. Okay, do you, we can call the meeting to order? Let's see, we want to do the attestation of conflict of interest, correct?
Right.
Let me just read this guy off. Conflict of interest means a situation which an interested person has potential to vote on or influence a matter that would provide direct or indirect financial benefit to that director or their immediate family, to any agency with which that member is affiliated. And then the self-dealing transactions, except as provided in the bylaws, the board of directors shall not approve or permit the Greater Columbia ACH to engage in a self-dealing transaction. A self-dealing transaction is a transaction to which the GCACH is a party and in which one or more of the directors has a financial interest. So please be cognizant of that. So,
Might pose a problem
please.
for us, maybe, just so we can, this is a great example of how we can apply this.
Yep.
But we talked about releasing the engagement funds in the distribution. Every board member agency will receive an engagement payment. So how do we apply that principle to a decision we have to make as a board? Are we adopting the policy and that's how we're saying it's different, or?
I was actually gonna bring that up when we got to that too, yeah. So that it is a concern. I think as long as you acknowledge it and you all say, yes, we acknowledge that our organizations are receiving funding, but, we agree that this, is going to be uniformly applied, and, it will be going to our organizations, but I think you have to acknowledge it in the minutes that there is a financial interest in the engagement funding conversation.
And our bigger purpose is to approve the methodology, not necessarily the individual payment.
That's right, yeah.
Okay.
And can I add to that? When I came to this board, it didn't have anything to do with my agency. I didn't even know about the money, and this is what I have passion for, and I think everybody around this table has that passion too. And it wasn't for any kind of monetary gain that I came onto this board, and I don't benefit personally.
You made it, Kim.
Okay. Thank you all. Next item on our agenda is the consent agenda. We've got board minutes. Have they give everybody a moment to take a look at the board minutes?
I motion to approve the board minutes.
Very good.
Second, Madeline, thank you.
Any comments or questions? All in favor?
Aye.
Opposed? Thank you. Next item is the Greater Columbia ACH report and some updates.
So we will share this report. It's now the GCACH report, and almost all the staff is participating and contributing articles based, on what they're doing within the organization. And so I have just the first couple regarding the practice transformation work group, and we kicked off with a meeting on April 12th. It's being co-led by Mark Wakai from Providence and Brian Sandoval from Yakima Valley Farm Workers, who have agreed to be the co-leaders. You can see who we had in attendance besides Providence and Yakima Valley Farm Workers: Consistent Care, Signal Health, Community Health of Central Washington, Virginia Mason Memorial, Kittitas Valley Healthcare, Molina Comprehensive Healthcare, Washington State Allied Health Center of Excellence at Yakima Valley Community College, the Blue Mountain Heart to Heart Organization, Tri-Cities Community Health, Eastern Washington University, and we had somebody calling in from Qualis Health. Who we didn't hear from, there were a couple of people that were not able to attend. Lord's Network, Barbara Mead from Lord's Network was not able to attend. And there was somebody else.
Me.
And Brian.
Yeah, I wasn't able to attend.
Right. Some of these people were already engaged in the Leadership Council through being facilitators of project areas such as Becky Groves, Everett Maroon, Jorge, Dan was on the workforce committee, Ryan Lance was on the budget and fund flow committee. So we've had some natural leadership arising through the Leadership Council. Then we filled it out to represent some of the larger health systems, knowing that at the end of the day, we have to be able to improve our metrics so that everybody gets paid. We really want some of the big players at the table as we approach this from a practice transformation framework. So we have recognized that our success is really linked to clinical practices becoming patient-centered medical homes. Fortunately, we have Sam Wardell that's going to be leading the charge and doing those assessments and getting into those practices. But because of that emphasis and that framework, we feel that the metrics will follow suit. And it really just matches the framework that we've already established through our culture of health in the 4 areas. So we're very thankful to this work group. We're going to be working them hard. They'll be meeting every 2 weeks to begin with because there's a lot of work to do. So our next meeting is next Thursday. Mike Benetti came up with this schematic, kind of a little icon. We're working on how do we project whole person care, how do we get the word out that whole person care really is, at the end of the day, what patient-centered medical homes really strive towards, and that the power of that whole person care is just so many benefits to the patients, to the systems, to the costs. So he's trying to develop a model for us that we can use as kind of our icon.
Okay.
We've had some staff title changes. Wes is now our new deputy director, and he's going to be really taking charge of a lot of the operational things. He's going to be overseeing Megan, and we've been putting together the leadership council meetings. This morning was a great example of a very, very successful meeting. Thank you, Wes.
Megan is now Lauren, by the way.
Lauren
Johnson.
Talking. What happened? Sorry about that, Lauren. Sam has transitioned to become the director of practice transformation, and then we added a little bit to Ruben's title as the community and tribal engagement specialist, and I think that that's a really important distinction. On the next page, Dan and I had an opportunity to talk with CDC about their workforce development programs, and so we highlighted a little bit about that. We got to see their new medical facility that's named after Rand Wortman that houses their paramedic program, their medical assistance program. What's interesting about CDC is that their medical assistance program contains the community health worker curriculum. And that has enabled their students to do community outreach and be hired and have a broader resume to be, to the community. And so in talking with Mary Horner and Kim Tucker, we got to view the laboratory, what they're working. And I think there's something like 620 clinical hours that they do in order to become a medical assistant. And there's absolutely no problem placing these students once they graduate from CVC. They're in high demand. So having that community health worker training is really important. As we talked about this morning, having case management with a clinical background, I think is really going to be important too.
Okay.
It's interesting that, so we recently did an 8-hour crisis intervention training where we were able to get West Valley Fire Department paramedics involved. One of their workforce challenges they're having is getting people very young through the program who really aren't psychiatrically prepared or defended well enough for what they're encountering that young in their life. So it's interesting that we're seeing a fast track that's going to get younger people into the field who maybe don't have as much life experience. And he says what they're seeing is that their careers are terminating early from trauma. So it's an interesting thing to keep in mind, especially as these things we're pushing for workforce development, getting people into the field. We need to figure out in the back of our minds how we're preparing to care for them and make sure that they get to have good long careers.
And Ed, I'm glad you brought that up. We just did a training, day-long training for about 35, primarily community folks in Yakima, to college. Karen Hill from Health Management Associates did a training on ACEs, the trauma-informed care, and with a specific focus on health workforce development. Because, yeah, we recognize that that's a real big issue. And I think it was Lori we were at a meeting at the Yakima County Healthcare Coalition. We were talking about that quick access or broad access, but quick exit in terms of workforce. And what's really unique and interesting, I think it'd be really interesting, particularly for our workforce committee to take up, is this question of how do we balance this question of pathways work, pipeline pathways work, and that a lot of the high schools and CTE systems are really advocating for quicker entry into healthcare professions, and we're like, and most of the people that are working in health workforce development are suggesting slow down. It's okay to kind of walk slowly into this, and yet from the K-12 system, the OSPI kind of lens, let's push them in. And so but we're not really having that conversation about the dangers of that. So I'm really glad that you brought that up.
And just to piggyback on that, I know Angelina has been from Farmworkers has been busy doing her mental health first aid thing. So not even just the new young ones, but even the existing ones who really haven't been properly trained or been given some resources to help them. So that's becoming more and more important, and she's getting a lot of demand to come do those trainings across Yakima.
Excellent. Very good. Thank you. So, what's the next one?
So several of us attended the Northwest Rural Health Conference. We each had some highlights. I don't know if Ruben and Sam want to talk about the things that you got out of it, but I thought it was really, well, I did the workforce track. I went there for Dan, but I learned a lot about the things that maybe are being concentrated on, especially in the Spokane area through AHEC. Maybe some opportunities that we could bring into Greater Columbia with more of a focus in this neck of the woods. But I thought that the workforce track was excellent, got some really good ideas about, I didn't even realize that Cadillac was doing this program through their high school. So it was just, I thought it was very well done. So congratulations.
Thank you. A lot of work. So I helped the Area Health Education Center of Western Washington organize the health workforce track. And Ben Lindekugel from the Association of Public Hospital Districts and I helped to facilitate kind of hopefully what was considered to be a little bit deeper dive. We got into both content as well as, you know, encouraging some the collaboration and partnership component and kind of the, again, you know, highlighting the takeaways of what you might want to walk away from. So just more, hopefully a lot more than just content. And it's good to hear that you had a good experience. Who else was there? Was it Ruben?
I really enjoyed it for someone, you know, who's new to the whole industry. There were a lot of sessions there that helped me in my development. I really enjoyed the main speakers, especially the young lady that had the car accident that caught fire. I mean, I was in tears, and so was everybody else. I attended several sessions. One tribal engagement, people going home visits to tribal elders in the Spokane area. They were all very, very well worth the investment in the travel.
And mine is actually listed on the sheet here under the Northwest Rural Health Conference, but I found it interesting that the oral health assessments, they were talking about children up to age or grade 3, that is the #1 chronic illness, and it's 100% preventable. And that was really enlightening for me to hear that, how we can integrate oral assessments into primary care. It's also reimbursable at like $70.29. So really being able to understand how we can, even though that's not one of our areas, but being able to go into transformation, we can at least be able to train them and initiate that primary care. So.
Okay.
Thanks for the feedback.
Awesome. I think Ruben has the next couple of articles. Do you want to talk about the next couple of articles that you wrote?
Yeah. Every time I take a bite. Yes, I've visited several organizations. I'm just, you know, very impressed at how every community that I go to, everyone's so passionate about improving the health of their communities. Yeah, I've put in a lot of miles. You know, there's a couple pictures. The first couple are from Yakima Tribe. They had a behavioral health open house, and you know, the young people there that was welcoming all the visitors, they were very, very passionate. They really care about their community, and they want to improve their health. So they let me take a couple pictures. The picture on the right, it's a health fair in the Vista Hermosa community near Prescott. They had about 800 people attend, mostly agricultural workers. So it was very, very impressive. Also, we extended our condolences to the Yakima Tribe on the passing of Russell Jim, and I cover that on this article. And I also, you know, give a little promotion there to the Blue Zone meeting coming up in Yakima, May 1st. So hopefully people, I pass it around. I guess the city of Pasco might be sending a delegation.
Well, I just said it yesterday, Tony Buechner's coming in at the end of September, so.
Okay.
The
That's
Blue
good.
Zone has.
Oh,
Have more lentils.
Not today, Megan.
Right.
So for Section 8, the initial distribution of engagement dollars, hopefully, you guys will hear about this a little later on, but Greater Columbia is definitely wanting to push some money out. Like I said, we'll review it later on, but just some of the engagement funding is hoping to be pushed out by June. And the Washington Financial Executor Portal, which hopefully you all know about. And if you don't, then Diane and I will be, spamming you with phone calls. So
Diane's on it with the emails already. I got one.
Yeah. So as you guys know, you have to be signed up in this portal to get payment. So it's a pretty important step. As of now, we actually had 3 I approved yesterday, so we're at 28 out of 70 providers right now. We're increasing, so that's a positive.
Can't say we're not trying.
Yeah, it is not user friendly.
I
I understand that.
I can say as an agency, we had a minor glitch to fix, that they were very responsive, very helpful, and we were able to resolve it between us and them within a day. So
yeah,
so
so we're definitely trying. We're just as Greater Columbia, we're kind of a middleman, but happy to be the middleman or middlewoman. There's also a training link listed there. It just kind of takes you, I think a few of you were on the actual training, but they recorded it, so it takes you through the process if you need any assistance at all upon registering. Just a LIN contract update. We have gotten 5 out of 6 of the LIN contracts fully executed and signed. Last week, we just made 2 payments to them because we received all the deliverables, and we're working with a third this week to get their deliverables completed, and they can obtain payment also. And lastly, my help right here, which many of you have talked to now, Diane Halo. So she's the Finance and Contracts Coordinator. She came to us from PNNL, and she has a plethora of experience across all ranges, which I love. But, I mean, finance, contracts, risk management. She's got 2 degrees that she obtained from CBC, so she's ready for the work.
Very cool.
You're welcome. Thanks.
Congratulations. Okay.
And I'll just keep going.
So Carol's next thing on here is the financials. Is that what we do next?
Yes. Yep.
Okay. On a roll.
Okay, so the statement of financial, the balance sheet, you'll notice that we have 95,000 in our checkings and 5,800,000 and change in the money market. We have a total of $5,906,000. And a plus, which I just figured out yesterday, is our money market interest is now at 1.24%. That's from 1%, so that's exciting. More money.
We're rolling in it now.
Yeah. The next one is budget versus actuals. Just like you've seen in prior months, it lists out our revenues. You can see we've made since January total interest on that money market, $14,729. There's within each category of the design funding, which is what we're currently operating out of. We've spent $222,615, which is only 13% of the budget amount that we plan for. So we're still being very conservative and on the lower end, but it should start kicking up. Some contracts are starting to ramp up. We still haven't spent anything more out of the Yakima Valley funding or the HRSA funding.
Okay.
And there's the total roll up down at the bottom of all categories. And the next 2 sheets, actually, there's just the overview sheet, and then for anyone who wants to look at extra details of how we spent that funding within those categories, is the following sheet after that. There wasn't any unordinary expense this month, so I won't get into that, but we spent a total of $56,911, and then after factoring in the interest we earned from the money market, $51,875.
Okay,
Anyone have questions about financials?
Nice work, great.
Thank
yeah,
you.
that's good. Thank you.
Very good work.
All right,
So do we have a motion?
oh, we need a motion, right?
I'll motion to approve the financials as
Sorry about that.
Second, Madeline.
Thank you.
Any comments? All, that's what I'm looking for.
All those in favor?
That's it. All in favor? Thank you.
Aye.
Any opposed? Thank you. No abstentions. Okay, so the next item we've got on here is the, we have financial policies to talk about?
Yes, just approved, hopefully.
Okay.
So we didn't print out, the whole 60 pages for you. It's just the title page and the table of contents of what it includes. It was passed at the last finance committee to approve it. I don't know how many of you have had a chance to review all of it. I'm sure it's riveting material.
I think it comes to you as a seconded motion from the finance.
That's correct, and I know that you've worked very, very hard on it. We've been through it a couple times
Yeah.
and cleaned it up.
So
and-
it's been riveting for you.
Yeah. It's been vetted a
All right.
few times, so I
That's
think
enough.
we are very comfortable making a recommendation.
Well,
That's good.
And
If I-
I did,
If-
have a question on our insurance coverage. It's at 1 million, and I'm just wondering if we feel that's adequate coverage for the organization. That's the only thing I had.
For director's insurance?
Well, it's, comprehensive liability is 1 million, directors and officers is 1 million. And just wondering if that's. Is it just 1 million, or is it like 1 million, 3 million?
I think it's 1,030,000. Yeah, it doesn't have the whole every category, but there is. I can also provide the printout that shows all coverage if you
If
want
it's 1 million, 3 million, I think it's adequate. If it's just 1 million, I think we might want to look at it.
And we just got the amended HCA contract this week too, and we'll have to make sure that it's in concert with the contract requirements.
But I think, but
I know it does meet the commercial requirements or within our
Okay,
contract.
all right.
So if we wanted additional, then
Mhm.
that's up to us. But it does meet the requirements of the contract. So.
Okay.
Well, I think that's probably the starting point, and if we need to come back to it later, we can probably do that, right? Don't you think, Madeline?
Yes, yes.
Okay. All right, so you need a motion on actually, we have a motion, right, from the finance committee? And so we need a second on the financial policies and procedures manual.
I don't second.
Oh, and you did that. Did you do that? Okay. Did it now? Any questions or comments? No? All in favor? Aye. Any opposed? Okay, thank you. So, next thing we've got on here, is also Kylie, the initial engagement funds payout, correct?
Yes.
Okay.
Okay, so this is what I kind of spoke on what we would get to in the GCACH staff report as far as the engagement funding. We're working on and we're going to be sending out this current state assessment, and it's going to take time, a lot of time from our partners, and we really want to be able to push something out for them to be able to work off of. So there are four categories, there we go, that we would like to be able to get approved, which has been approved by the Budget and Funds Flow Committee and the Finance Committee, to be able to push out these payments that relate to these topics. So the first one is the submission of the LOI. Second is the participated as a project facilitator during the project plan application. The third is being a board member and participation in that. And the fourth is registration with the financial portal.
Could you, just let people know what the amount is for each one of those?
Yeah, so submission of the LOI is $1,000. The project facilitator is $5,000. The board of directors being on the board is $1,000, and registration within the portal is also $1,000.
I don't think being on the board was
It was last
It was-
month.
Yeah,
Was it 1,000?
Yeah.
It was the project manager one that was hired.
Oh, okay.
So if we made all payments, assuming all 70 LOI providers signed up in the financial portal, I just did 100% participation. So that would be 167,000 from the Medicaid, 45,000 from the non-Medicaid, for a total distribution of 212,000. And it's a very minuscule amount. It equates to 3% of the total engagement dollars, which is the 7,187,000. So Greater Columbia really just wants to get out this initial payment, get providers, you know, more engaged, because money drives engagement. So that is our request. So the proposed recommendation is the board accepts the initial distribution recommendation for eligibility requirements for revenue allocations to be paid out. First payment, May 2018. So, yeah, that was the first one, like the first initial one, because it still got like the 33% and the 50. Okay, because it's been reworked, it hasn't changed anything. Yeah, whatever. We're on.
Okay, so let's put a motion so we can talk about it.
Also move it.
Okay, thank you. Do we have any questions on this piece, on the funds flow discussion? Because we've been through this too a few times, right?
Yeah.
Yeah.
Okay.
I have a, sorry.
Go ahead.
Okay, this is Lori. I have a quick question. It's really not related to the, I understand the eligibility requirements. Is this then, is this then followed up with some kind of a MOU and a statement of work for what each participant will be doing for that total distribution of $212,000?
So for these payments that we want to push out, they will not have an MOU prior because they have been completed already. So we aren't requesting anything in return for this funding because we have already obtained it.
Right, these are the kind of showing up payments.
Basically, like,
Yeah, this is coming out of the LOI.
So later in the year, yes, there will be a contract for further.
Okay, so there is
Okay.
no expectation for that funding, is what you're saying?
Correct.
Other than showing up, submitting a LOI.
And attaching into the portal.
And getting in the portal.
Yeah.
Correct.
I think that's the startup dollars.
Should be. If you sign up for the portal, that's your task.
Well, it's actually entices a lot of people to get in the portal. Just saying.
Just reimbursement for engagement, that's fine.
Yes.
Correct.
Right.
And they've signed an agreement, a master agreement in the portal.
Do we want to talk self-billing transactions right now? Since we all technically would have one as board members and a payment for board members. So are we in agreement because it's fair and equitable? We're going to bypass that?
I'm wondering if that should be in part of the motion. I could amend the motion
Okay.
to make sure to acknowledge that has been acknowledged by all of the board members.
Okay. Do we have a second? I don't think we got a second.
Not yet.
Second.
Okay, thank you.
By Megan. Thank you, Megan.
I think that, you know, just having the startup where we spoke about acknowledging that we've got the conflict or self-dealing component, I think is probably sufficient. But yeah, I think it's appropriate to mention it in the notes.
I have a question. So in this capacity then, are the MCOs not able then to take funding because it's coming from the Medicaid waiver, Caitlin? Okay.
We are not allowed to be participating providers.
Okay.
Okay.
And if you're employed by the state, it's not a conflict. Is that correct? I'm
It's
just,
not the healthcare authority, right?
what's that?
As long as it's not the healthcare authority? Yeah.
I would say. Yeah, if you're DSHS or something, you should be okay.
Community college system. so.
Right,
Yeah.
but that,
Yeah.
you're separated from the funding, I think.
Yeah, DSHS
Somebody
and
did call.
HCA for sure do not submit LOIs.
Yeah.
What about the AAA?
Yes.
Okay,
Quick question,
yes.
what's the avid member on the board of directors versus,
Well,
Heather?
What is not an avid member?
I mean, I could interpret what that means. Someone who regularly participates.
Yeah,
Yeah.
please show up.
In fact, I used that at the AHEC board meeting on Tuesday regarding what we call MPRs, minimum participation requirements. And,
Right.
I will say Better Health Together has a minimum requirement for their collaborative and payment as well. You have to be at least 2 out of every 3 meetings.
well, I would assume it's following the charter, which
Yeah.
is 75% meeting.
Right, we've done all those things.
Okay, so that's the definition of avid.
75%.
And Dan, you're.
Or was it a typo that was supposed to?
And we need to be in the right place at the right time.
That's probably-
Exactly the rest of it.
How they do that.
Well, I was wondering if there's like.
So Megan, you're gonna
They
be.
walk in, we're like, oh.
I thought maybe
That
it
was
was
early.
personality characteristics.
You know what you don't want to be is the avid board member police, right? The guy who gets to pick. Like, no, man. Dan, I'm sorry. No,
And I just want to clarify on this too. It's the organization that's getting it, not any individual that's
Right.
sitting around
Yeah,
the table.
Correct.
And then also technically representing all sectors. So I don't know how that fits
That's right.
in, but
That's true.
so I think we have multiple ways of getting out of any conflict.
Okay, thank you.
Okay, are we ready for, all in favor? Of the, approval to release those funds, right?
Aye.
All right,
I wasn't sure if you actually called that or not.
I did.
Okay.
Any opposed?
Who made the motion? Darlene, and who is the second?
The motion carries, thank you.
Sorry.
How many people do we have on the phone?
We have,
About-
Lori. Any
No, we had,
abstentions? Lori?
oh, sorry, I was gonna say, at one point we had 9, I just don't know how many of them were board members on the phone.
Oh, yeah, I don't know. I think, was Lori,
Is John Sinclair on the phone?
I don't think, John, are you there? I think Lori was the only person.
Yeah, I think so.
Okay,
They have to vote by saying.
all right, so this motion is carried, correct?
I guess.
Yes, we have enough people to have a quorum and all that good stuff. Okay,
8 in the room and at least 1 on the phone.
yep. Okay, very good. Thank you. The next one is Carol, revised, PT, that practice transformation work group charter.
Right. So, the board approved in February what was called the Strategic Planning Work Group Charter. And since that time, we have looked at the scope of work for this work group and determined that it really should be called the Practice Transformation Work Group, since the framework of our implementation plan will be seen through practice transformation. When we met with our consultants, OHSU, they suggested the name change. And probably one of the biggest changes was they felt that this committee was going to be required to be nimble, with rapid turnaround, making decisions quickly. It would be a lot better for operationally if we could have it be a work group of the staff, basically, and not come under the auspices of the board of directors, because then all of their recommendations would have to come through the board of directors, who only meet once a month. This group is being scheduled for every 2 weeks, and we are going through a very rapid cycle of looking at selection criteria, making recommendations in terms of project planning, implementation, aligning our projects, looking at selection criteria of the providers that will be in the first wave of contracting. So this new revised charter reflects the 4 focus areas of the work group. And I'm not going to read it out loud, but
You can see from the changes in the charter that basically they're going to be reviewing regional data and helping identify the appropriate selection criteria for providers to receive PCMH technical assistance. That's going to happen this Thursday. I sent out the homework to them. Selecting providers to engage in the PCMH transformation process. And again, we have 155 clinics that are embedded in these 70 LOIs, and so they will help us determine, what's the first wave. And the current state assessment will really get at who's really interested. If there's an organization that really is not that interested in doing this contract work or becoming a patient-centered medical home, then we'd like to help concentrate on those organizations that have a readiness and a willingness to be a part of the program. They'll be reviewing the GCACH provider assessment and identifying regional strengths and weaknesses to better inform the selection of providers and application of change strategies. Meaning when we get back the current state assessment and we already have LOI information, we have to be strategic in where we put these projects. We might decide that there needs to be a heavy concentration, for example, in Southeast Washington to address the opioid crisis. They'll be taking a look at the data, saying, we really need to concentrate, let's say, in affordable housing in Yakima to get people, the treatment that they need for opioids, whatever. So this working group are comprised of, I mentioned earlier, a lot of clinicians, experts in their field, the facilitators from all of our project teams, and then they represent the majority of the Medicaid clients in our service area. And then another big task is monitoring the PCMH provider performance and making any necessary adjustments in strategy or tactics. So as we start getting the reports back from our providers, we're looking at their performance, just kind of keep an eye on, how are we doing? Do we need to beef up investment in this hospital system or this health system? And then we came up with some guiding principles that really were somewhat of a flip of the responsibilities from the previous charter to bring voice to the various sectors and domains, to ensure that the providers involved with PCMH activities address target populations, health disparities, and health equities, to provide timely review and feedback on the documents when solicited, to support and lead PCMH change efforts in their respective organizations, and to support the vision and mission of the GCACH. We are also acknowledging that we're going to be paying the organizations of the people that are on this committee. We're asking a lot of their time and energy, and so we'd like to compensate them for not being at work. So we're suggesting through the Budget and Funds Flow Committee, there was a $15,000 allocation to that organization. And we're not requiring necessarily it's that person, but somebody from their organization that can come and help us make these really important decisions moving forward. The other thing that I think is very strategic about this is that we know change is hard. That you just can't walk into an organization and say, hey, I want to change the way you're doing your workflow. So we're going to need these change agents within these organizations. And so we've selected people that we think can be very instrumental in helping us do that. And kind of be the disciples and getting the word out and helping Sam and her team kind of the forefront as they're going into these organizations doing their assessments to help open the doors or to remove barriers. So that's was a big request of this work group, but we got a lot of really good feedback at our last meeting. We didn't have any pushback. And I think that there's a couple people here that can talk about their experience on the work group, but these are the changes that we're suggesting, and we're asking for board support.
So if it doesn't report to the board, what do you see that looking like? Would there just be like, and would that be part of the director's report?
Yes.
Then you just include that in your every meeting.
And major decisions are going to be coming through the board anyway. You guys will always have control of all the financial decisions. But as operationally, we'll take all of that feedback.
I think it makes a lot of sense.
And then you, as the Budget and Funds Flow Chairman, there's lots of, so Ryan Lance is on that committee representing that Budget and Funds Flow. So we have kind of this cross-pollination of people from across the region. I would like to suggest adding maybe a couple more seats for people because we don't have anybody in Southeast Washington. We do have interest from a woman named Leslie Robeson, who is from the Pullman Blues Family Medical. she's a psychologist, so I'd like to see her on this committee because we don't have anybody from that neck of the woods. And I think it's important to have all regions represented when we're talking about how do we do health equity, how do we allocate, you know, the first group of providers that are going to be in this system.
So we have a couple big deliverables this year, like we did last year. Last year we had two certification plans and 1 project plan. This year we have a mid-year review, which is in large part this current state assessment that we've talked about. It'll be incorporated into that. The big piece will be the implementation plan, which comes at the end of September. That is a really important document. And this particular group will certainly inform that and probably the mid-year plan as well. And so as Carol was talking about, this cadence of every other week is going to be really important. As we've learned, those dates approach you a lot quicker than you think. And there's just a whole lot of work that goes into the development of that. And we really need the feedback from these individuals to tell us, Carol and I and Sam and Kylie and Diane and Lauren and everybody and Ruben. I mean, we all have great thinking around this, but we need reality checks. We need to be kept in line with what's realistic in terms of provider implementation.
So can you remind me, could you remind me who's on the board for the different domains? On the, says members of the PTW will be nominated and confirmed. Who are those individuals?
So from our board of directors, it's Brian Gibbons and Ed Thornbrew. Mark Wakai is also in the hospital system. Brian Sandoval from Yakima Valley Farm Workers representing the FQHCs. Then, Lori, we have the 3 leaders of the project team. So we've got Everett Maroon from Blue Mountain Heart to Heart and Becky Groves from Consistent Care Organizations. We have Lily Gonzalez, who will be new. She is from Virginia Mason Memorial. She's a clinician that runs their diabetes outreach programs and education. She's a clinician. She's a physician by training, but she's not a physician in the United States. She came here from Mexico, so she hasn't gotten licensed in the state of Washington. Ryan Lance from Budget and Funds Flow.
Jorge for data and HIE.
Jorge for data and HIE. I think there's 17. Dan Ferguson representing Workforce.
There's for MCO, there's GCACH.
Yeah, Kat Latte is also on the Workforce, and she was also kind of helping co-lead the bidirectional integration group. We've got Barbara Meads from the Lord's Health Network, Lydia Minnick, and actually it's going to probably be Richard Lay, they're pharmacists for Tri-Cities Community Health. Mike Maples from Community Health of Central Washington, he's also a physician, and they have a great residency program that they're running. Who am I missing?
That's a great team.
Quality out. So I have a question, and I think I'm just blanking on how it's going to roll out. But that list is very medical, and Ed's on it. But that's one BH. Did you say that, Darlene, you're on it? No. So how is BH rolled into this for the bi-directional?
Right. So I said Becky Groves, Ever Maroon have really strong backgrounds in behavioral health, and Brian Sandoval is the co-leader, and he's a psychologist. So you know, and he's really familiar with the whole bidirectional integration piece because Yakima Valley Farm Workers.
Yeah, and Central Washington Family Medicine, the residency program has a very integrated program for.
Yeah, so PCMH is like in the acronym is medical home.
Right.
And so PCMH doesn't necessarily work for like CACH charities. It's a different way of assessing and trying to figure out the right model. And so I'm just kind of wondering how that's going to fit in for the BH agencies. And you both are very sophisticated. I'm sorry, pointing at Ed and Darlene. But there are some other agencies that aren't as sophisticated, but they'll need a significant amount of help. So I just don't know how that.
And one of the things I can say from the last time we met, one of the questions I raised was about unintended consequences. And I think what you're seeing is that the separation of people who've been providing the BHO level of care versus there are behavioral health integrated clinics that are not at the BHO level of access to care. And we've talked openly about our concern about unintended consequences of cutting out the seriously mentally ill and seriously emotionally disturbed people.
Yeah.
And doing a great job of improving prevention and depression screening, that kind of stuff. So we are having really open conversations to make sure that the whole Medicaid population is being considered when we're looking at practice transformation.
Okay.
And the measures that we're looking at, they don't differentiate between severe persistent and those with lower lying mental health. We have to address everybody to meet those measures.
Except we recognize it's going to be easier to get compliance and participation from people without this more severe end of the spectrum.
Right.
And that's why we're looking at those warning indicators. We're leaving groups behind.
So when we did our target population formulation last year that involved HMA and tenfold health and identifying the populations that might be high cost, high utilizing, SPMI definitely was part of that. It was an important part of that.
And Caitlin, we're really looking at transformation of care. PCMH is just a model that's underneath transformation. So we're looking at the bidirectional and really focusing on that population management and being able to do the risk stratification and making sure that we're looking at the overall population as opposed to just a PCMH model.
I understand that. I just think that PCMH doesn't necessarily work if the BH provider is the primary point of care, because it's not, they become a behavioral health home. It's different. It's a different model.
Right.
And, you know, there's a lot, and this isn't a dig against medical side of anything, but there's a lot to be learned from the BH side and the way that they treat patient choice. I mean, patient-centered medical home is a somewhat new concept for medical care, but in the BH side, that is the recovery model. That is how they approach things. So I'm just curious of the cross-learning that'll end up happening as we go through integration. I don't want us to be so focused, and this isn't just here, it's happening everywhere, but just so focused on helping the medical side bring in more BH instead of trying to think about how the BH side has already done this for years, and we need to honor consumer and patient choices.
Definitely, and their instincts are more valuable as well.
The medical side has fixed goals and we even see it in our measurements.
Yes.
Of, you know, we want to see gap to goal improvement on A1C. Well, on the recovery-oriented systems of care, we negotiate, and there's a voice in the treatment plan, and they may say, I don't want my voices to go away, but I want to be able to go back to work. Right. That's a very different thing. If they're saying that, well, I don't want to have an A1C of 6, I want to have an A1C of 7.5, I'm happy with that. That doesn't align with our metrics and all the medical goals. And I think that's where we want to have those conversations.
That's a great analogy. That's true.
And then the last thing that and it's not really having to do with the charter, but I'm just trying to understand of how we're going to get information, and because Kat and Jorge have already sent us information as a sector, but the things that are being talked about at this work group really does impact us entirely as a sector, and they cannot get out information and receive feedback fast enough in 2-week increments. But like VBP and stuff like that cannot be talked about only with them, and they know that. And they would never even try to represent all of what we're trying to say. But I think we just need to figure out another avenue for the 5 NCOs to be involved, because if this really is setting out implementation, we can't just have 2 plans trying to decide that. I'm not saying that you are, but it's not necessarily a representative model. They've turned it into that, but that's not what this is designed to be.
Is there a site where information could be kept and logged into?
As far as?
So information that comes out
The
of this.
presentations and things like that.
Yeah.
Well, we
so
have
that-
it on our website.
You know, a small mechanic on that, and we have pushed for this in other regions, is that we all are in the same list, whether everybody attends the meetings or not. We still share information, but just having all MCOs in the mailing list, because it's important for everybody to be up to speed, and sometimes it might take a day or 2 or a week for somebody to send an email saying, hey, this is what we discussed in that meeting. I don't think there's any harm in sending the same information to all MCOs. And then if Kat and I are the only ones, then we find other mechanics for us to share information. But it doesn't take much to just add everybody.
And I think anybody that requests could be on that email list, right?
Absolutely.
It should be.
If the board wanted to be, consistently on that list so that you would receive that information, that could happen as well.
Sure. It's not a secret process.
I think the bigger point, going back to Caitlin's first comment is really about how much PCMH really drives the conversation here, and if that is exclusive of the imminent work that we all need to do integrated managed care. I really never read the presentation as this is all that is going to be done in the region moving forward. It's very much about the waiver projects and how they get implemented, et cetera, and there's a couple that are have to do with behavioral health integration, but we shouldn't take the eye off the other work, and because there's a lot of work in the same table we just discussed it 2 weeks ago, everything that needs to be done with behavioral health providers. I don't necessarily think that we need to bring more behavioral health people to the table on this, but we have seen across the state and our experience, for example, with Molina in the Southwest, that shows that sometimes the smaller providers have a voice or have things to share that the larger providers don't have. So small SUD agency, it's only 4 people, they really make an impact in the community, and sometimes their realities are quite different from the better funded, bigger footprint organizations.
I think you raised some really good points, and as we met with the providers a few weeks ago, we had a great turnout. So we had a provider meeting that was the result of the fully integrated managed care and the Greater Columbia Behavioral Health Organization becoming a behavioral health administrative organization, BHASO. And so basically, Greater Columbia BHASO has kind of washed its hands, I think, of the BHO providers and said, the ACH will take care of you now. And so we are trying to work very hard and diligently with the behavioral health providers. We had offered to set up the next meeting. They resisted and said, no, we just want a chance to kind of regroup and realign ourselves. And so we're standing by, and Sam is standing by to help work with them, doing the MEHAP assessments and try to get them engaged and into the system as well. They've all been sent letters of interest. I think we've gotten letters of interest from almost every single one of them. And so they're in the system. I think there's somebody that was calling in today from Quality Behavioral Health. So, we're starting to engage with them more and more as we're splitting off the duties between the BHO and the ACH.
I think the most confusing thing at that meeting, as I talked with some providers that had kind of not heard a lot of the information, was what the BHO would be getting for incentive dollars for really moving in this mid-adopter, and then what would come through the ACH. I think that people were kind of going, like, what's that look like? And so that probably was one of the takeaways, kind of as you think of the next steps, that people that have not been very engaged with the ACH process, and then that was one of the things that was talked about at that meeting. And there's not any pathway. There's not like a footprint with that right now. So it's just, the clarity is not there. And would be happy to provide that clarity once we're invited, to the table, and can work with them. But we've been actually prohibited from contacting the provider organizations until this separation happened. And so it's been a little bit frustrating for us to be able to get the group together. But now that we've been given the red, the green flag, full steam ahead and working with the providers, $4 million, in that pot of money, in the incentive pot of money, so that we can help them get the electronic systems that they need, or the IT infrastructure, the training, the education, the consulting support. So it's waiting for them. We just are waiting to hear from them to take the next step.
Right. So who's blocking you?
The director, Troy Wilson.
So if that doesn't happen, Ed and I can help with that.
Yeah.
I mean,
I think it's important to recognize too that there really are a couple of issues at hand. One is the BHO has been the system manager for the Medicaid benefit for
since 1993.
Right. And so there's a difference between the practice transformation and the integration, the bidirectional integration, which are the projects we're engaged with. And their role is looking at handing off the financial integration. So these are really 2 separate books of business, but they overlap because we're using some common terms. And so regardless of what we do as an ACH, all these providers still have to go negotiate agreements with the selected MCOs to continue to be a Medicaid provider in the future. well beyond the remaining 3 years we have. And I think that vision gets lost. And I think, you know, we may be getting blamed for them losing their jobs in January, when in fact, these are really two separate books of work.
I think at the same time, and what happened in Oregon with health system transformation is they forced system transformation before the financial transformation. And so there was no clear funding mechanism to pay for system transformation. So I think that even though they're parallel processes, there is a nexus in that point of where if you're asking providers or telling providers sitting, you know, this is system transformation, there needs to be those contracts in place to be able to be reimbursed by it really quickly, if not already in place. Otherwise, they can't do it. They can't get the staffing in order and do it. So.
When do NCOs hear back from the healthcare authority?
May 22nd.
We do not.
I was going to say, didn't memorize that date at all.
So it's only a month.
Yeah.
Okay.
Yeah.
Fingers crossed.
So the process.
And it doesn't affect our region. The outcome of the RFP doesn't affect our region.
Well, so it doesn't necessarily, but everybody had to submit an adequate network. If you couldn't get an adequate network here, then that could affect it. I don't know if everybody did or not. We may or may not.
It's different than the RFP North Central in the sense of the way that instead of being a score network where you get points based on how weak or strong, it's a pass fail. So I think that's I think, you know, so what you're saying is you're assuming the 5 plans are going to remain unless there's like a huge.
Right. There's a big gap.
Unless there's a fail.
Which is possible, and
Yeah.
obviously there's been some recent action to.
Yeah, and we've all had to attest that we had reached out to every BHO provider, not every BH provider, but every BHO provider to try to contract with them, depending on the region and the BHO provider in the 2019 regions that was. They may or may not have decided to do that at this time, because they didn't know how many plans would be here, what plans would be here.
Okay. What else?
Do you need action on that? Yeah.
Yeah, I'm wondering, right, I'm trying to figure out where we are. We were doing the charter, right?
Charter. Right.
Okay.
So the recommendation is on the back of the charter is that the board of directors approves the revised practice transformation with the charter.
Do you want to, at some point, also indicate that that's going to be under operations? That this charter is going to be under operations, not
Yes,
board?
I did change that in the charter. On the second page, Darlene, under membership, leadership, and appointment process, it says the PTW will be a work group of the GCACH organization and meet monthly, or as often as
So it's been moved. Do we have a second?
Sandra.
Second with Sandra. Any additional comments? Okay.
Yes, thank you. Seconded by Sandra.
Thank you.
And so all in favor?
Aye.
Any opposed? Any abstaining? Okay, motion carries. Thank you. Very good. So now we have a little line in our deal here. So I think we're moving to the audit discussion, correct?
Yeah.
Okay.
So, I mean, this may or may not require action, actually. It depends on, I'm not sure if everyone had a chance to review the proposals. So we got 2 proposals returned, one from Moss Adams and the other from Northwest CPA, who has been our accounting firm. During the finance committee, it was moved to move forward with Moss Adams. And if you turn to the second page of both of those proposals, they gave you a layout of the cost. Both services whoever we choose to audit will also complete our 990. The Northwest CPA, though, they don't include the cost for the 990. They're just based on the audit. I think, so Ed was in the finance committee, and he had Moss Adams prior to, I think they just switched agencies, he said, and Moss Adams was amazing. And just from communications between both of these agencies, I can say that Northwest CPA has not been responsive at all, and Moss Adams responds within the hour. They're they've been very good and involved. thus
Will Chris
far.
Rivard be the partner that you work with?
Would which, sorry?
Chris Rivard be the partner that you actually work with?
Yeah, so, oh, they didn't. The full proposal does have, it provides us the
Yeah.
4 individuals that will be working with Greater Columbia, but yes, Chris Rivard is.
I actually have that, and I remember seeing that last night. So they have a pretty extensive, presentation.
Yeah, the full proposal has, I mean, all of their references, they have reference letters, the 4 individuals that would be dedicated to Greater Columbia. It is very, very expensive.
And there's the team right there.
There we go.
Hmm?
There it is.
Oh,
Thank you.
yeah.
I know Chris. I just wondered kind of who else was.
Mm-hmm.
Mary, right?
Is Chris on service our engagement leader? So that's good.
It's good. Okay, thank you.
Okay, so there's a recommendation from the Finance Committee to move forward with Moss Adams, and so we need motion, I think, to accept that recommendation.
I think that comes as
Or
a
it comes as a seconded motion.
Call the question or have discussion.
Okay, any discussions beyond this? Thank you. All in favor?
Aye.
Any opposed? Any abstain? Okay, thank you, motion carries.
Yay. Nice to be done.
Kylie, the next one is also your benefits discussion.
Oh, yes. So this was our, I just wanted to give the board an update on that discussion because we finally finalized it all. So for medical, vision, and dental, we've moved to Assurus, and we've given a breakdown. The nice thing about Assurus is that we now offer the 2 plans, the preferred plan or an HSA, so employees are able to pick which one they prefer. And we did the cost analysis based on 6 employees. Currently, only 5 are eligible, but 1 will be eligible next month, so we just want to show the whole cost. $610.33 per employee on either plan that you choose. It's only $505 for the HSA, but we're going to be doing employee contributions to the HSA card to make it equal the $610 in the preferred plan. So with 3 employees projected to choose on the preferred plan and then 3 on the HSA plan, each come out to $1,830.99. So the total cost for benefits for us will be $3,661 on that. So that's just a heads up too. On the next financial statement, you'll definitely see an increase in health benefits.
Mm-hmm.
And then dental, we're sticking with Delta Dental, which was $58 per employee. So that'll be $348 per month. And then for our retirement plan, we decided to go with a simple IRA. We maintain the 3% match that was approved, and just being maxed out, assuming all 6 current employees that we have do 3% and contribute that, max amount that we would match is $16,950.
And they'd be eligible after the 90 days.
Yeah, and currently only 3 of the employees are eligible right now, but
Okay. Is there an entry date, or it's just after the 90 days you can go?
it's just after the 90 days.
Okay.
I did have a question.
That doesn't need a motion, that's just a finish.
Yeah, it's just nothing, right?
Yeah, that's good.
Yeah, it was approved in February.
Yeah. So I had a question, because we had it in the employee manuals that we were going to approve the retirement benefit, and we approved that back in June. So I just was wondering if there's an obligation for us to have provided that for the prior month.
So I think what we kind of came to the conclusion was is we will just start from when we initiate the simple IRA, because they have maxed out. It would be very difficult. I mean, it would have to be done over time for us to input into their IRA. And not only that, you'd have to take the input from the employees, their contributions, to match them. So it would be a mess. So we just kind of decided to initiate it when it starts for everyone. So
You have to change your taxes too.
Yeah.
You'd have to go back and refile and
Yeah.
redo those documents. So I wouldn't recommend that.
yeah, it would be a huge mess.
I mean,
it's
Good
definitely
idea.
a benefit, but yeah. They might not feel like it's such a benefit if they have to go back and do all that work and refile taxes.
There is a way probably that you could do a one-time payment. It depends on how your plan's written, a one-time payment, but I don't know if we want to consider that. But it would have to be obviously in this calendar year.
And I do think that it's a one-time payment the employee can choose to contribute because as a retirement plan, I think you can do a little bit of catch-up. So I do recall seeing.
I think it's just something to investigate if employees are interested in that.
Yeah, I can definitely look into it. I would question though, if, I guess we would be collecting from the employees too, because it's a match
Because
and not
it's
a.
match.
Right,
Yeah.
You would, and so
Okay.
it would be an employee option.
I think you
But
should.
it would do what Madeline is.
Yeah, I'll look into it.
Yeah.
So you can see.
Okay, thank you. That's good. Next one, participating provider workflow, Carol and Wes.
So, you remember the little target that we had, and just trying to take everybody through how to get to our project application process. So we've done a similar thing with the participating provider workflow, knowing that a lot of you are participating in the project application process and trying to give you an understanding of where we're at with the workflow. So obviously all of the LOIs have gone out and we've collected those, and we're now, you guys have authorized some engagement funding that can go out. And the next big thing will be this provider selection criteria questions, which the practice transformation work group will be looking at next Thursday, that include the criteria. I don't know, did you all get this criteria, this sheet?
Yeah.
So it will include this suggested list of criteria that was taken from a number of resources regarding practice transformation, and hopefully get at their readiness level and their willingness to be a part of this program. At the same time, we're trying to get this current state assessment out, and the current state assessment is a requirement Wes had talked about. By the end of July, we have to have a current state assessment of all of our participating providers in a number of areas, including some pay for reporting measures. Where are they at in terms of opioid training and education, and where are they at with bidirectional integration, and then we're going to take the opportunity to extend this survey to ask very specific questions at the clinic level, you know, about their readiness and willingness to look at PCMH. So that's hopefully going to go out soon.
It's in a Frankenstein mode right now. I take it on its own.
Then we have the provider engagement fund flow model that Darlene is working on, and we're still trying to build that engagement model out. What does the rest of that model look like in terms of how do we include social determinants? You know, how do we link it to all of the different project areas that they're associated with? At the same time, everybody's trying to be signed up for the financial executive portal. So a lot of these things are not happening sequentially; they're kind of happening in tandem. Eventually, we're going to get to this participating provider selection, at which point then Sam and her group will be able to go out and do the assessment, the practice transformation, the PCMH and MEHAP assessment, after they do a little bit of training. And now I'm at the practice transformation implementation work plan phase, which has to be handed in by the beginning of October. At the same time, we hope to get enough information. We'll be working on these provider contracts, and then we can release the second round of engagement funding. So it just kind of gives you an idea of what the workflow is going to be for the staff and what the providers should expect between now and October or November.
Wow.
A lot of work.
Yeah, that's a lot.
No vacation this summer, huh?
Yeah.
It looks like not.
We've also thought about trying to put together I didn't write down what it was, but a gathering of all the providers, if possible, sort of like what's going on in North Central, to get feedback and do some other work. Whether or not that will happen within this time frame.
Are you thinking like the kickoff day that they're having tomorrow? Is that what you're thinking of, or what do you think that looks like?
Well, so we were part of a discussion that was put on by Qualis where some of the ACHs got together, and at least one or two of them had talked about doing something like that, bringing all the providers together to sort of, fully initiate the process, let them know about what our strategy is, and then get some engagement from them.
So it's the second one that's happened in North Central.
Right,
So I'll
right.
definitely let you know more information about that after tomorrow. I think
That'd
it's
be
a great idea. I really
Yeah.
do think that the Provider Summit is an opportunity to bring everybody together. Here we are, we're going to be doing the work,
So it was so popular that they cut off the registration 2 weeks ago.
Wow.
Yeah, I've heard it was really well attended.
Mm-hmm.
I actually tried to go up there and be part of it, but they didn't have room, just to see what they were doing.
We listened to a practice transformation meeting the other day, and Peter Morgan was on the phone, and their process, they're way ahead of us, but their process sounds so familiar with what we're trying to do as well. I think that we'll be able to use their model and slide right into it, because they've established the Whole Person Care Collaborative, which we really like, because the outcome of all of this really is, patient-centered care, whole person care. So
Yeah, and maybe it would even be valuable to have Peter come down and talk with us about that.
that's a great idea.
Yeah, he's available. But, in listening to some of the other ACHs, it seems like the work that we're doing and the process that we're following is pretty consistent. Pretty consistent. I mean, I think ACHs are kind of, some things are ahead of others while other things are behind others. It all just depends on which particular organization that you're looking at. But this idea of focusing on the practice, primary care, medical home, practice transformation, I think we're learning that that's the direction to go to move all these projects in tandem.
So I see they have to do assessments, and then they do the work plan that comes out of the practice transformation implementation, or is that the practice transformation work group that does an overarching work plan?
No, so each provider, and Sam can talk to this, will be doing its own transformation implementation plan.
Okay.
Right.
So based upon their assessment, we will do a benchmarking, and I'll meet with them about what goals they want to achieve and where they want to go with those goals.
Okay.
And then that
Right.
implementation plan will be formed out of that.
So part of that assessment will include workforce needs?
Yes.
Okay.
And is there some, visioning about what we want the system to look like at the end of all of this, to then set up the implementation plan, sort of backbuild them? Because some of the other regions and their implementation structures in North Central somewhat like this, is that they have these providers working collectively instead of individually to incentivize more provider partnership in between community-based organizations and medical providers, and between medical and BH, which creates a nice structure for like an ACO-like model or some sort of pooled VBP arrangement. So I'm just curious. I don't think we've had those conversations here, but I've also been in a different world for 2 months. So.
Well, if I'm reading what you're saying, kind of, maybe it's analogous or similar to what you're talking about today during our presentation with Everett and Becky. They talked about this ORN, opioid resource or referral network. And to me, that's a collaboration that would involve BHO providers, BH behavioral health agencies, primary care, EMS, ED physicians, social service agencies. That's a great opportunity for collaboration around a particular project area. Certainly there's overlap with practice transformation, but it's like a Venn diagram. It's not like this. It'll be a lot like that.
Yeah, I think I'm thinking less on the individual provider and more at the systems level administratively, because that's who we contract with. So, if I'm contracting with Sunnyside and can incentivize Sunnyside to work with Catholic, and then also some of what we're thinking of is if the ACH pays Sunnyside in a way that makes it so you are kind of forced to contract with housing providers to work on referral processes, we can come in on the back end and wrap around a contract related to that, because we can create something that's flexible enough that allows them to do that without using their own resources outside of Medicaid. I'm just trying to think of.
Yeah, that's a big vision. I hear what you're saying, though. I mean, and I don't think that's, to your point, I don't think that has been
you know.
Well, I don't want to even say talked about. I don't think we've imagined that yet.
Yeah, okay.
I don't think we're there, but
But
that's good.
But I like those
Place
ideas.
we gotta go, yeah.
Yeah, you know, Carol and I
I do
are
too,
around.
that's great.
We like to hear that because we like to know, you know, what's possible.
Yeah, that's like you shove the boulder another turn,
Yeah.
and that's okay. I mean, that's what we gotta do.
And I would say, Caitlin, within our culture of health framework, we do have 4 major drivers out there with integration of services, care coordination, health equity, and community empowerment.
Yeah.
So we're really trying to pay attention to of moving all of those cogs and the wheel together, and because we know that those really, that integration between the practices and that level of cooperation is going to move the needle much faster. So I think there's been a lot of tension, the tension within the practice transformation work group is how do we make those clinical community linkages?
Yeah.
And how do we make them work? Is it contractually? Is it just that they see this natural alignment? You know, they start working together because they find out that they might have behavioral health providers that can work in another health system. So we're going to try to make those connections through the practice transformation team. But also, if we need to, we can always use that lever of encouragement and incentive dollars to do that.
Okay. And I think
We're probably gonna need to eventually.
And the other thing is that Sam is really good at is that she knows the billing side of all this, and so she can show the providers, hey, you know, if you do these oral screenings or these fluoride treatments, you're going to get paid for it. Hey, there's funding now, according to Ronnie, you know, you can get paid for some housing supports and things like that. So we'll have to figure out how that looks like in a contractual relationship.
Yeah, we just learned yesterday that there's a set of codes under ICD-10 that are called Z codes that allow for diagnosing social determinants of health around housing, employment, and the rest.
Right.
I didn't know that those were billable, but from what I just
They are
learned.
now. They are through the American TPA.
Yeah, I mean, that's fantastic. That incentivizes providers to start aggregating that data and collecting that data from the consumers.
as well as supportive employment.
Right, that just
Yeah.
came through, the supportive housing piece just came through, and the supportive employment, we're doing a LCSNW, and we'll probably be doing the supportive housing as well, because, our youth going through those programs that we have, they're really challenged with job equity as well as the housing. And a lot of them are coming out of that, going into 18, and the parents are dropping off. So those 2 components coming under Medicaid are really necessary to keep them supported and elevated so that they can be successful.
Yeah.
We have Jacob Avery coming out to Walla Walla mid-May, and so once I get the exact date, I'll let you know, because it doesn't have to just be Walla Walla, but we need to get all of our housing and employment providers contract. It's going to be a requirement to receive local housing funds from the county to be contracted with AmeriGroup moving forward, and so we'll once we get that data identified, I'll share it with you guys. I told him I'd like him to get the biggest bang for his buck for coming out to Southeast Washington.
So we're actually already a contracted provider, and I'm going to just make sure everybody's aware. I mean, it sounds great, it is great, but the doorway for people to qualify to get through to those services is pretty narrow.
Yeah.
So it's not a general open.
Yeah. So that's a demonstration.
Well, and there has to be severe impairment, chronic homelessness, or severe impairment in access to employment. So it's not intended to replace the existing stuff now, or even to be as accessible. It's a very high bar. So
it is,
it's
in my
good that we're doing it.
to do that locally for Walla Walla, I can't speak to any other community in GCACH, is that whether you're able to capitalize on that contract with AmeriGroup or not isn't my business, but as long as you have a contract with AmeriGroup, that if you have a client that comes through your doors that you engage with that is eligible for those services, you can bill AmeriGroup for that rather than utilizing local funds. But those local funds, and with an increase of about $150,000 for Walla Walla with the past bill increase in $2160 and $2163, you know, we'll still have the local funds to support it, but it's nice to have the supplemental funding in a sense for the next 3.5 years. So.
Okay.
But that initiative 3 hasn't been talked about a lot yet, and so I had to go out and figure it out.
And Tori, who runs it for AmeriGroup, can always come to the board and give a presentation.
Who is it?
Tori does. She runs it for America. She's Jacob's boss.
Oh,
Jake?
great.
He is great, yeah.
Another thing that I'm doing when I'm going out and assessing or meeting with the different clinics is looking at available resources or participating linkages that they would like to have, and Darlene can actually speak to that. So really making sure that we're working with the community to join those resources and be able to benefit from those.
Well, just going back to what Caitlin said, so kind of good conversation. I don't want to like derail out about Initiative 3, but when you were talking about end state and kind of backtracking, I think what you're trying to get at and what I'm thinking of is how do we make this sustainable post demonstration? And so while these incentive dollars are great, but they're going to go away, or we have to assume that our state may not apply, or if we were to apply, would get, you know, a renewal of this waiver. And so I think it's the notion of talking with providers and what's the ultimate end state and what could be sustainable, and backtracking those change plans or those implementation plans from there. Because if we're just changing the system, but without the mind of what are we going to do post, you know, 4.5 years or 3.5 years from now or whatever, we're creating this system that's then going to go revert back. So I think that's, I know it's like big vision, and it's hard to think about like sustainability when we haven't even started. But I just want to echo that, because I think some of the other HCHs are, as they're developing, you know, for lack of a better term, maybe change plans for providers, it's with that lens, and that might be just something for us to consider.
And I think, Sam, isn't sustainability built into the model? Yeah. So I do think that that's why we were really struck with that, is that we absolutely need to have that sustainability built into this, because at the end of the day, we want our providers to be comfortable with value-based contracting and to be able to show and demonstrate how that can happen. So that's where we're excited about TCMH, but looking at the end goal really about patient-centered care. You know, that's who we're all in this for, right? Yeah, a patient.
Yeah. But I think it gets to Caitlin's point about incentivizing the provider-to-provider connection and collaboration, because that's what's going to ultimately help sustain this post-demonstration.
Right. And making those linkages.
Yeah.
And I don't think you guys are behind, or that's not what we're trying to say. I think it's more that in other regions, there are natural ways of breaking their region up that have allowed their providers, they're more contained. So like in their county, for instance, they have a one system of care in their county already, and they already work all right together, but now the system centralizes them to work more closely. That doesn't exist as much here, because there are health systems and providers that cover so much territory since it's so rural. It's even very different than Spokane, where they still have very contained county-to-county collaborative. So it's challenging here. I was just curious. I think I spoke
It's okay. You know, we are piloting now. It's getting underway a project to try to improve provider-to-provider linkages electronically.
Oh, that's great.
So,
Yeah.
and we'll be informing the group
might
more
solve
about that as
everything.
it evolves.
All right. We don't have action that needs to be happening there, right? Next item was selection criteria discussion.
So just, I wanted to let you know that this is what we are using on Thursday to discuss with the Practice Transformation Work Group. Again, a lot of these criteria then link in with the values of patient-centered medical home, and trying to get at provider readiness, willingness to be in the program. And then obviously another criteria is you have to be practical about, you know, how many Medicaid beneficiaries do these particular clinics have. And so this will actually be at a clinic level. We want to get detail at the clinic level. So as we send out this survey instrument, then there will be space for all of your clinics to be able to participate, whether that's 2 or 15 or 19. I know, I'm sorry, but you're getting paid, right?
Okay.
So you can approve the funding for it.
And there may be a subset of the total number of clinics that a health system has, just depending on how the criteria falls out.
So since this was one of the things we were struggling with the budget flow, so when you're looking at volume, what we were looking at with the budget and funds flow is that we have organizations that are Medicaid providers.
And then we have organizations that also provide services to Medicaid recipients, but they're not billing Medicaid for them because they're being funded under a different entity. Is there a way to get at that information on here if there's other Medicaid recipients that are being served in some capacity, but they're not billed through Medicaid?
It's going to be a challenge to try to get out that information. I don't know an automated way to do that, to be honest. I mean, if there was a report that came out of, DSHS, HCA, or whoever, but we tried doing that just to come up with a client count, and that's difficult.
Mm-hmm.
So other than self-reported, it's hard to estimate that. In a lot of those organizations, I don't think they differentiate between payer type.
So at least this will give us the information based upon the clinic that is in the counties that are in the Greater Columbia area, because some of the organizations that we had in the LOI cover counties greater than the Greater Columbia area, and that numbers were totally, they weren't split out. And so we want to make sure that this is specific to this area.
An interesting thought. I guess when you get to it, the overall goal, right, of the whole deal is impact the dollars that Medicaid is spending.
Right.
So if somebody else is funding them, Medicaid's not going to care about that.
Of outcomes.
I know, that's what I mean. I agree.
Yeah.
That's why it's a challenge.
Yeah.
Okay.
So there's a series of questions in the survey that will follow each one of these definitions that will kind of get at some of the answers, but we only just kind of included the selection criteria so that you would have a chance to see it.
So you could end up with a subset of provider clinics.
Exactly.
It's interesting.
Yeah. And as far as we know, we might be the only ACH that's doing this at the clinic level. I think there's a bunch of them are doing it at the systems level, but we have 155 clinics. We need to figure out how we can help and who really wants to help and how we can assist. So we think that getting at more granular data will be helpful too.
And our collective experience has informed us that just because 5 clinics are operating under the same health system entity, they may not be performing at the same level.
And their operations aren't the same as well.
Exactly. So,
Sam and I were talking, and I had a moment of panic yesterday, and she calmed me down today. That if you're counting the number of clinics as the number of LOIs that came through.
No.
So you'd have all 56 of our treatment locations included in your 100 count of 150
are there
potential partners.
Are there 56 in the ACH?
There are 56. Well, no, because White Salmon and Goldendale will go to
So there are
Southwest,
54.
so 54.
Yeah.
But we're talking about multiple styles and types of programs. She calmed me down, don't worry. But we may have multiple health systems that really have this dynamic range, that there may be a golden opportunity that we hadn't even considered once we do sit down and go through the deals. So you guys really have a lot of work set out for you.
This practice transformation is a gigantic lift. In her area, she'll have 2 other people, 2 navigators that'll be supporting her. I'll probably be supporting her. It's not going to all happen in 1 year. It may happen over the course of 3 years, but we have to improve the metrics over 3 years. So in a way, the staging of this progression might work to our advantage.
Yeah, we have the same thing. We got 15, 18 clinics too.
Yep. In one county, right?
Yeah, that's wrong. Okay.
So part of like the system LOI is then that allows you guys to go in to do the assessment on the clinic and then select the clinic
Right,
within the system.
But this CSA will also kind of direct us to which clinic when we see the performance.
Yeah, that's really fascinating.
Yeah.
What's the date on that?
Tuesday.
No, what's we haven't approved this yet. So the practice transformation work group will take a look at this criteria. We'll send it forward to them to say, what do you think? Initially, we hear some questions, and so if they have any suggestions or changes, we'll see that on Thursday. But otherwise, we want to go out next week. Go out next week and come back.
But it's going to take time to get it back.
3rd week of May or something.
So about a month.
for somebody to have some examples, like Megan talked about, being value-driven, willingness to go upstream to address but it didn't sound that way. But when you're talking about if there's another resource, you must be willing to engage it. So you have to look at the merit group if you're operating in our area. That's a real good concrete example, I think, of, demonstrating those principles or just having some ideas, because I wouldn't have put those two together until you talked about that. I'm like, oh yeah, that absolutely makes sense. If it's available, we should do it. Even if you're only going to do it for one person, you're leveraging where possible. So that might be helpful.
So hopefully we'll get enough in that definition section, Ed, to make sure that people understand that. We'll ask you're on the team, so you can give us
Just
feedback.
some scenarios or something like that to put it into real world terms, because I may just be more prone to panic this week. But it helps. It really helps.
When I think those those Medicaid providers who aren't billing Medicaid that's an opportunity there too, to engage them and talk to them about why aren't they billing Medicaid? I have those conversations all the time in Walla County because we are a funder who makes it so they don't have to bill Medicaid. And, having those conversations of, no, you have to bill Medicaid whether you're a Medicaid eligible client. That is a missed opportunity there. And it is usually using up other resources, or resources that would be available for other purposes.
But if you have another contract, you can't double bill. So
Yeah.
there's some other contingencies.
Yeah, so it's kind of, getting the root, I think root cause is really critical here of the practice transformation. But I think that systems level that Caitlin's talking about is really critical. And it happens I think what Madeline was saying, it happens kind of at a sub-regional level too, in a sense. We do have some natural boundaries around, there are systems that cross into several, like comprehensive is in, more than half of our region, but I think that there's natural partnerships established within most of our counties, at least, and even sub-counties. The local health improvement networks are the perfect example of that.
Right.
So I think capitalizing on that is really critical with practice transformation.
And you recall that we had that conversation about, are we going to fund networks, right? And there's great interest, and I think there's great value. We're just not there yet because we want to kind of walk before we run and be able to do these individual assessments. And then as we learn about, learn more, then I think that opportunity will come up. But right now we're going this route, and hopefully we'll get to network incentives. And there's 3 years of a demonstration, so.
Right. I think we're very confident that this is the right approach. If we want providers to start thinking and planning and doing for value-based care, and if we want it to be sustainable, we don't want this to, as we've talked about several times, it's not just a grant process where we pay them to do some activities and as soon as we're gone, it stops. This is really, and at the clinic level, then this is really the most effective way to do it. It's just a lot of work that other ACHs don't have the scale, the geographic footprint that we do.
The way I see it is, doing individual clinics, and this is what I just did in Walla, individual clinics, and bringing everybody together. So it's a tiered approach, and so you have to establish that relationship and trust with those. Right.
They're going to be like the individual, I'm going to take pharmacists. So if you had 4 clinics, but then there may be conversations between you all as administration and then those 4 clinics together, because if we were to, be negotiating some sort of contract or any MCO, they wouldn't be doing it with the individual clinic. It would be with the administration, and that's up to you all whether or not you support the clinic in that way. It's not like you wouldn't, but I just know
there's a possibility we wouldn't, though. It depends on the clinic and the resources, and that's something that we'll have to look at. We'll have to cross that bridge when we get there, but there is a possibility that we wouldn't, because how do we get there? We do try to make things pretty standard throughout our system, so that's, now we're going to pump some resources, and you know, that might be worthwhile. We want to move the same metrics that the ACH wants to move, so, you know, it may be worthwhile, but how we do that and in the timeline we do that in, that could be different.
Yeah.
Right. Different organizations may be at different levels along the spectrum of progress. And we'll know that when we go in and do those baseline assessments that Sam and her work group are going to be expert at.
Well, that's another question, though. There are groups that are progressive, and how are we acknowledging that in this process, too?
I think we will deal with that when we come to it. And
Okay.
yeah.
Just another question.
Right. We need to, I think we all have to have a mutual agreement about where everybody's at. And until we do these assessments, we won't know.
Yeah.
So we'll be providing feedback during our work group meeting on Thursday.
Yeah, and we
about
sent,
these definitions.
and we sent this out to the practice transformation work group last week. So to try to give you some time to do that homework. So.
All right, are we good?
Okay.
Huh?
I gotta get on it.
Well, do. Okay, so
You're gonna have the magic wand?
I think the next item, Carol, is to go into an executive session, correct?
That's it, yeah.
Okay.
How early?
Is it executive session with everybody or just executive
And
committee?
Evelyn, oh, that's where I did my question. Rhonda and.
That's the two of us. Okay.
Wow.
I know you haven't been used to that.
Oh, no.
So you guys go somewhere else.
That's it, you've been in meetings all day.
I think the executive session can be everybody, but I think
But it's the executive committee.
executive committee was going to review Carol's
They were really excited.
deal. Do you have a minute
Yeah.
for this?
So is there performance?
I think so, yeah. And that was Karen and
need it.
William. We did. I think Rhonda and, yeah, we did do that. And we went